Compartment syndrome is a critical condition that every nurse must be able to recognize instantly. It is a limb-threatening emergency where time is of the essence. Early recognition doesn't just save tissue, it saves lives and limbs. Hello everyone, welcome back. I'm delighted to have you join today's session. In today's class, we'll be discussing compartment syndrome, one of the important emergency conditions you may encounter in your Ireland aptitude exam and also in clinical nursing practice. By the end of this session, you'll understand what compartment syndrome is, why it occurs, how to recognize its warning signs, and how to perform an appropriate nursing assessment. So let's get started. To understand this condition, we must look at anatomy. Our muscles are organized into compartments, each enclosed by a tough, non-expandable layer of tissue called fascia. Think of it as a tight sleeve that holds everything in place. When swelling or bleeding occurs within these tight spaces, the pressure rises because the fascia cannot stretch. This increased pressure compresses blood vessels and nerves, leading to decreased circulation and potential tissue death. Simply defined, compartment syndrome is an increase in pressure inside a closed muscle compartment. Because the fascia is rigid, this pressure restricts blood flow, depriving muscles and nerves of vital oxygen. It is, by all definitions, a surgical emergency. If we don't intervene immediately, permanent nerve damage and muscle death can occur within hours. This is why acute compartment syndrome requires urgent surgical decompression, known as a fasciotomy, to relieve the internal pressure. As nurses, your primary tool is the clinical assessment. We use the classic 6 Ps to monitor for neurovascular changes. These are pain, pallor, paresthesia, poikilothermia, pulselessness, and paralysis. Let's break these down. The earliest and most important symptom is severe pain that is out of proportion to the injury. If a patient's pain is not relieved by elevation or standard analgesics, or if it increases when you passively stretch the muscle, your suspicion should be very high. Paresthesia, or a pins and needles sensation, is another early sign indicating nerve compression. Pallor follows as blood flow is restricted, causing the skin to appear pale or dusky compared to the unaffected limb. It is crucial to remember that pulselessness and paralysis are late findings. If you wait until the pulse is gone or the patient cannot move the limb, significant damage has likely already occurred. We must act long before we reach this stage. There are 2 main types you should know. Acute compartment syndrome develops suddenly after trauma and is a surgical emergency. Chronic or exertional compartment syndrome usually occurs during repetitive exercise and typically improves with rest. In the aptitude exam and acute clinical settings, you will primarily be concerned with the acute type. While chronic cases are painful and limit performance, they are rarely limb-threatening in the same way an acute injury is. What causes this pressure buildup? Fractures and crush injuries are the most common triggers causing internal swelling. However, external factors like a plaster cast or bandage that is too tight can also create a closed compartment by preventing expansion. Other causes include severe burns, which can lead to significant edema and tight eschar formation, and vascular surgery where blood flow is restored to a limb that has been ischemic for a long time, leading to reperfusion injury and swelling. Failure to recognize the signs leads to devastating complications. Beyond muscle and nerve death, the breakdown of muscle tissue releases myoglobin into the blood, which can lead to rhabdomyolysis and acute kidney injury. Ultimately, it may result in amputation. I cannot stress this enough. Early diagnosis and prompt surgical intervention are the only ways to prevent these permanent, life-altering complications. As the nurse, your vigilant assessment is the first line of defense. Before you begin the physical examination, proper preparation is essential. This is especially true for the OSCE. Always start with hand hygiene, introduce yourself clearly, confirm the patient's identity, and obtain their informed consent for the assessment. Professional communication is just as important as the clinical steps. Explain what you are doing, provide privacy, and ensure the patient is in a comfortable position. This builds trust and ensures you gather accurate information during the painful assessment. To understand the patient's pain in detail, we use the OPQRS team mnemonic. This structured approach ensures we don't miss any critical details about the nature and severity of the patient's discomfort before we move to the physical exam. Starting with O for onset, ask, when did your pain begin? Was it sudden or gradual? Then P for provocation. What makes the pain better or worse? In compartment syndrome, passive movement of the limb almost always makes the pain significantly worse. Next is Q for quality. Ask the patient to describe the feeling. Is it sharp, burning, or a deep aching? And R for region and radiation. Where exactly is the pain? And does it spread anywhere else? Localized, deep pain is common in these cases. Finally, for severity. On a scale of 0 to 10, how would you rate your pain? And for time, how long has it been this intense? A high severity score that is increasing over time is a major red flag for acute compartment syndrome. Thank you for joining today's session. Always remember, early recognition, prompt action, and effective communication can save a patient's limb and even their life. Keep revising, keep practicing, and never stop learning. I'll see you in the next lesson. Until then, take care and happy learning.